Hello, everybody. Thank you so much for joining us. I am Jen. This is Adarian. This is part 2 of the ACL and collisions podcast. Actually, it's part 2 of the Let Me Introduce You podcast about ACL and collisions. So last time we talked about ACLs and collisions, right?
Right.
And how collisions can be wanted, well, they can be extended or they can be not extended. And that can create wanted or unwanted vibrations. And this could potentially be a mechanism for ACL issues, correct?
Correct.
Okay. So today we are going to take this one step further and look at some of the protocols for return to play. But first, I think it's useful to look at these numbers a little more, because last time we talked about, there's this emphasis on preventing ACL injuries. Am I making that up, or have you seen that too?
No, like I said, they got protocols. They got protocols now for teams and things like that on how to prevent these ACL injuries. ACL injuries, non-contact ACL injuries, and everything. Right. And like I said, you have this just 2 or 3% population that this has been invented for. But now the other 97% of the population also has to do these things. So you have this thing for this population that really wasn't getting hurt at an alarming rate or epidemic rate, or, the word should probably be acute.
It should be acute, because if you look at some of the stats, like between 1999 and 2019, 51 players in the European Football Association Soccer League suffered a complete ACL tear. I don't know how many players there were playing in that decade, but I have to imagine it was a lot.
It was more than 51. It was more than 51,
So 51 is kind of a small number when you really think about it.
And let's go at it. That was a 10-year cohort, right?
Yeah.
So that's 5 a year.
Right.
So let's go 5 a year, and I don't know how many teams there are, how many players there are, but we assume there's 11 players on each team. So it's already 22 people on the field. So if you play in, let's just say there's 5 teams.
Yeah.
That's 100 players already.
Right.
So we can't say that half the players got hurt.
Right.
But if we go to data and say that's 2 or 3%, then we go, okay. But yeah, and think about, you're playing for 90 minutes.
Right.
Stopping, running, jumping, cutting, all this other kind of stuff, And I guess that's the other question too, is like, why don't we expect people to get hurt? I mean, shouldn't we? Somebody like the plane's going to crash at some point in time.
Yeah.
So that becomes the ot's part of it too. Is that 51? Okay.
So that's that, and 41 of those players returned to play, most within 1 year of their injury. The average return to play time took 216 days. So from the occurrence of this injury to getting back on the soccer field, playing at a high level, 216 days. That's a long time, don't you think?
Yeah. That's what, almost 3/4 of a year, a little bit short of 3/4.
Yeah.
60%. Yeah. 70%. Yeah, you go, well, 365. Yeah. 60%. So yeah.
Which is kind of, yeah. After 3 seasons, most of those players were playing at pre-injury level or better, except for attackers who demonstrated a continual decline in performance, which I thought was interesting. I don't know why attackers would have,
Yeah, why they would be different than everybody else.
Right.
But I think it's a running thing.
Okay, what do you mean?
Well, I think, like I said, I'm not a big soccer knowledgeable person, but I think attacking somebody is running more than other ones.
Oh.
And so I think that's the problem, is you have this running thing you have to do. And that may wear its players up at the most, and you have to be, So, but let me look it up real quick, just so I can speak on some information and everything.
Okay.
While you do that, I'll look this up.
So while Darian's looking up information about attackers, I'm going to talk about the NFL. This is fascinating to me. So in a 2022 study in the Orthopedic Journal of Sports Medicine,
What happened?
they looked at ACL ruptures and repairs in NFL players. This was between the years of 2013 and 2018. 312 NFL players underwent ACL repair during those years. To put this into perspective, there are 53 players on an NFL team. It's approximately 1,696 players in the league for a season. The average career of an NFL player lasts 3.3 years. All right, just so you guys have these numbers in your mind. So when we look at these 312 NFL players, 174 of those athletes return to play. This isn't a huge percentage. If you think about it, this is just a little over half.
Right.
312 players, 170 return to play. 28.5% were still active after 3 years post-injury. But again, their average career length is only 3.3 years. So
Right.
it's hard to know like where they were at in their career when they ended up with these ACL ruptures. Overall performance decreased in all positions after the ACL repair, except for quarterback, where performance generally improved compared to post-injury. But again, if I'm not mistaken, quarterbacks typically have longer careers than the rest of the players on the team, don't they? I believe this is the case. I could be mistaken.
Yes, quarterbacks have the longest, but quarterbacks have the longest career because, even with bad knees, all you gotta do is throw the ball. You don't have to really do a whole lot. They're not really dependent upon, they stand, they throw, things like that. And at the same time, they have longest careers too because they can go to a backup role. Like you can have a 20 careers, now you're not even play.
Okay.
Or once you have, you could be the backup guy and, you're that guy. So that's the difference too, versus, you're a running back and you go for 3 years and you have a bad year, you're not the backup anymore. You're pretty much out of the league.
Right.
But another position would be, offensive linemen, defensive linemen, they have long careers too. And they're in the trenches and they do, but they wear braces. I think a lot of, in college, I don't think in the NFL they wear, but in college you see a lot of players wearing braces. That offensive, defensive players wearing braces in college. I don't think they do it in the pro. I don't think so, but I was look closer at it.
Got it.
So, but what are the numbers again? I want to go through the numbers one more time.
I think they're super interesting. So in between the years of 2013 and 2018, there were 312 NFL players that underwent an ACL repair.
So that's a 5-year period.
5-year period. There's approximately 1,696 players in the NFL per year.
So 60 players. Let's go 60 players a year.
Okay.
Out of 1,600.
Right. Right? Like.
So what's the math on that? Is that still in that percentage range?
I think so.
Let's see what it is. This becomes the fun part. So, all righty. So we had how many?
1696. And 60, we're saying 60 NFL players per year are getting.
So that's like 5% maybe. So $4%. So it's in that range.
Okay.
4%.
So basically we're looking at like a 3 to 5% thing.
That seemed to be the range. Yeah, that seemed to be the range.
This gets even better. You're gonna love these numbers. This was again fascinating. So in the US last year, there were over 120,000 ACL injuries. So we'll call it 120,000. They said over 120,000, but that could be, like 122,000.
120,001 is over.
Yeah, exactly.
Yeah, like how you take the numbers, 2 dozen. Less than 20. Okay, go.
The majority occurred during high school and college. There were 7.9 million high school athletes in the US,
Yeah.
in 2018. And there were 520,000 college athletes in NCAA programs last year.
You're talking about 8 million people, 8.5 million people.
Yeah.
And so our concern at 8.5 million is 2%, 3%, 4% of the population.
Yes.
Wow. Well, now, if we go back to the NFL, did they say they were non-contact or contact injuries?
They were both.
So that number. So how many were non-contact? Because the
Oh,
contact you can't do. I mean, somebody rolling your leg, somebody that we can't do anything about. So let's give them half. Let's give them half.
Okay.
So we give them half. We back down to 2-3%.
Right.
And that's one player on the team. So that's one player is going to suffer an injury. Let's just put it that way. One player on every team is going to suffer some type of. Okay. I got 50 some odd players. One. So
right.
So just depends. Hey, just depends. Which one you want to be. Hey, could you imagine at the beginning of the year? Okay, pick one of them over there. Who's it going to be? Who's it going to be to suffer this injury? Okay, pick you. You got it.
Well, but I think what's more concerning about all of this is less than 50% of these people that have ACL repair return to pre-injury level of sports participation.
But okay, let's go this way here, and I feel bad for them, but and like I said, because we don't know what position it was. So like, let's go back to the soccer thing.
Yeah.
The striker is the person that's supposed to be the fastest and the person that's supposed to be able to score. So
okay.
They're doing more than anybody else as far as cutting, stopping, kicking over, kicking this way, kicking that way. So they're doing the most because they are the ones that's supposed to be scoring.
Okay.
Versus somebody that, like the goalie. And it would be interesting to see like how many goalies have, how many midfielders have, how many, and you got to figure, slide tackles. A lot of things happen in soccer that somebody can slide tackle you and it may not show up till, 20 minutes later, like, oops.
Right.
So it's always stuff, but so that's the numbers there. But yeah, you come back to that number about how many return. And I think, like I said, the biggest thing is what does that mean?
Right.
Because do they have measurements of pre and post?
They're trying to get that a little more standardized. They try to base it on, and again, this is hard too, because you assume an athlete is going to grow during their career. So if you've got someone that has an ACL injury early on in their career, maybe their first season, and they come back from it, a year later.
Right.
And then the next 3 years, they continue to improve. Well, they were early on in their career. They probably would have improved anyway, right? I mean, this is what we assume athletes are going to do. Right. Whereas if you're at the end of your career and you get an ACL repair, or like the late part of your career and you get an ACL repair, how's that going to play out?
Yeah, and even talk about from just a rehab issue. Younger players should rehab easier than older players. Right. Different habits and things like that. But yeah, but it's still a weird. And like I said, so that becomes the biggest thing here. Like, yeah, what are we measuring this outcome on? Right.
And they, like I said, they're trying to standardize it, but they're having a tough time. So the return to sport takes an average of 7 months across all of these different types of athletics. It can vary anywhere between 2 to 24 months. 24 months to come back from an injury is a long time.
Long time, yeah. Yeah, very long time. But once again, is that because they're overly cautious?
Right.
Versus aggressive, and is that a money thing? Like, if I'm because we've seen like star players come back faster than non-star players. Yep. So is that because they're more healthier, because they got more money, they got a better doctor, better surgery?
Right.
That would be an interesting fact too, to say like who's coming back the fastest?
Yes. Well, and why would they come back faster than a young player who gets an ACL injury, who's not a star player?
Right. Or even 2-star players, one may at the end of his contract. I mean, it would be interesting to look at it's not conspiracy theory thing. It's just a matter of what is the player. I mean, think about it. If I'm at the end of a contract, what am I willing to do to come back fast? Because I'm at the end of my contract. Whereas I have a long-term contract, am I going to come back as fast? I mean, it would be interesting if they heard all that kind of data too, to say who,
Right.
And then, like I said, and I guess if they're looking at stats, the stats would tell, about the performance level. I think that's what they're looking at. Like, what were the stats before? What are the stats afterwards? But once again, if I'm on the up and coming, then my stats might get better. If I'm on the way out, my stats might not get better.
Right.
They might decline. So that becomes the other part too. Yeah, what is it being based on?
Right. And it's hard to standardize this.
So,
but
yeah.
But where they go from here is they come up with an ACL protocol that is pretty standard.
Right.
So there are some main goals of ACL repair rehab. They're to restore prior level of function. This is number one. They want to restore strength, which we'll talk about.
well, let's go back. Let's go back to the first one. What is prior level of function? What did you define that as?
Well, again, it depends on what you're doing, right? If you're a 50-year-old skier and you rupture your ACL, maybe your prior level of function is different than the defensive linebacker, right?
Right. So yeah, that's why I wonder what does that mean, prior level of function. But yeah, does that mean that if I was just a janitor, I go back to being a janitor?
Right.
So,
and maybe it is. Maybe it's, I don't know.
Or I get to retire from being a janitor. Which one is it? I did this neat thing and now I can't be a janitor anymore. Okay.
That's a good point. So then they want to restore strength. But as you and I talked about before we got on this podcast, is strength really a part of an ACL rupture?
Well, yeah, because it's like a lot of people talking about I'm going to measure the strength in this joint. How do you measure the strength of a joint?
Right.
How do you we still struggle to measure the strength in a muscle, let alone a joint. So how are we assessing the strength thing? Is it certain exercises? Is it being able to walk? Is it being that's like we saw the one thing where the guy says, hey, if you can do so many, you got to do the single leg squat or single leg toe raise or whatever the case may be, and they have to be within a certain number of each other. A certain number of each other, that means you're balanced. Yeah. Like, that's all you got to do?
Which is very low load.
So yeah, well, I think a lot is low load. I think a lot is. We look at somebody. Because I'll say before we get to some of the exercises that they recommend in this protocol. So is those only two things, or are there more things they look at?
No, there's more. So they've got range of motion, proprioception, neuromuscular control, joints.
Roll back again. How do you measure proprioception?
That is an excellent question.
How do you measure that? So okay, go ahead. Go ahead.
Well, and how do you measure neuromuscular control if you're going to go with that? Because there's a lot of ways you can accomplish a movement task, right?
Right. And we still know the pre portion of this.
Right. Joint stability, and then to reduce fear of movement. Because one of the things they have found is one of the issues with ACL repair is there can be a lot of fear about loading the knee, or loading the leg, I should say. It was injured.
So, yeah. Well, is the fear of loading, or is the fear of falling because the leg may give out?
Oh, I think it's probably the latter now that you say that.
They may, so which is normal, so yeah, okay.
So these are the main goals of all ACL repair rehab. This is what they're all trying to accomplish. There's two philosophies. There's a conservative approach versus an accelerated approach.
Okay.
What researchers have found is that the accelerated approach leads to improvement in both elite and non-elite athletes within disability. So there's less disability, there's less depression, and there's less pain when you accelerate rehab, which I thought was really interesting.
Right.
There's increased functionality and improved quality of life, but it gets you back to what you're doing sooner, which would make everybody happy, right?
Right. That's the whole point. How do we get back to this sooner rather than later?
Right. since,
So.
you know, as I said, a lot of people, it takes them a long time. So then we get to the protocols. We're not going to go through all of them for this. We're going to, for the second portion that will be on the observing movement site, we'll cover this a little more in depth.
Okay.
But the main exercises in the protocol, I'm going to start with phase 1. There's 6 phases. We're going to go through 3 of the phases. This is 0 to 2 weeks. So somebody has just cut into your knee. They've maybe done a hamstring graft, or maybe they've taken a cadaver and, you know,
Right.
gotten the tendon from there. They've done the thing. Is to reduce swelling, minimize pain, restore full extension. So this is, they're concerned about range of motion here, and improve flexion and restore patellar mobility. Can you talk about patellar mobility at all?
Well, it's a weird thing, because if you talk about patellar mobility, your knee has to be moving.
Hmm.
You know, but so you're talking about patellar mobility, you got this, you know, just joint, and then you have this thing called range, you know.
Right.
If I'm working on range, I'm already working on this mobility thing. And mobility is a weird word, because, you know, the knee can only do flex and extend. It's not,
Right.
there's not a whole that the knee can do. Flex and extend. So, and I get it when I first, and I think part of it too is when they first test range, I think they test range based on you sitting on a leg extension machine.
Yes.
You know, you're trying to go that way. And I imagine that doesn't feel too good on this fresh suture. You know?
Yeah.
I mean, because think about this here too. Think about this here too. What's the hardest position to get up from?
I don't know. I get up and down from the floor all the time. Sitting?
Sitting is the hardest position to get up from. Why? Because look at what you really can't rotate, and that's, you know, I have put the word rotate in there, but your tibia is stuck right here.
Right.
And you don't have the leverage. You don't have, you know, which is why we use our hands to help it get up first, or we do something else. So now you're in a situation like this here where they tested something. There's really not still the best way for that to operate, you know. But that's how we test that. And we test it from the open end as the closed end, you know, the foot's open end, not closed end. And I think, you know, but these things are happening from a closed end perspective.
Right.
So that's, but yeah, it's like you can only do one or two things, this and that, you know. And
Right.
you want the patella, you know, the patella's got to glide and all that kind of slide back and forth, you know. But once again, this becomes, and this is once again, did they cut the patella? I'm trying to, did they do anything with the patella?
I think I would have to watch a surgery
I
on
gotta watch
YouTube.
because I'm thinking, like, they don't do anything to the patella. Why am I worried about the, you know, because
Right.
the biggest thing, especially now with the scopes, a lot of times they don't even cut you anymore. They go up to scopes and you got these 2 holes in you and they go about their business.
Right.
You
Yeah, it
know?
is weird
So
when
it's
you think
weird
about
that-
it. Like,
Yeah. So I gotta look this up real quick. Go ahead, I gotta look up something now.
okay.
That's what it's for. It's just like, hey, let me stop a minute.
So what we've got going on with the exercises for phase 1 is walking without crutches begins when there's no increased pain or infusion and patient demonstrates proper gait. Now, again, this begs the question, who's determining proper gait and what does it look like, right?
Right.
We also have, you can ditch the brace after 6 weeks. So you're in a knee brace for the first 6 weeks for standard. Then this came from Massachusetts General, which is, they had a very well outlined protocol, but I looked at other protocols. They were all very, very similar. For stair climbing, it is recommended that you lead with the non-surgical side going up and you lead with crutches and surgical side going down. What do you think of that advice?
Okay. So I was looking something up. So this becomes, yeah, okay. So let me roll back. So yeah, it's so what we thought it was is just that they basically moved the kneecap around, patella movement. Like, you go in flex and extend. This thing has a glide on top, so you're talking about that. But in some surgeries, they take it from the patella tendon and graft from that.
Oh.
That's why I'm thinking, like, why would they mess with patella? So I get it. Yeah. If you graft from that, different story. Yeah, your
Got it.
patella is sore, hurt, and everything else because we just took something from it. Got it now. So, but once again, you know, when you talk about these things, you know, about how we're doing these things, that's a pain issue that you're dealing with.
Right.
We know pain stops us from moving. So you can't do anything to let pain subside if they graft it that way.
That makes
Just
sense.
just like they graft it from your hamstring, you're gonna be hurt for a minute. You can't take a piece. I mean, if you take a piece of skin off your body, it's not gonna be happy until that.
Right. Okay. So that makes, okay.
That makes sense. But even that there, you know. But let's go back to this once again. Let's talk about these mobility things. How mobile is my patella in the first place?
Well, hopefully not very, right?
Not very. That's what I'm saying. So not very. But like that's what I told you. I got this. It does this and this and this. As this does this and this. And the patella kind of slides on top. That's why I was like kind of slides on top. I don't want to move left. I want to move right. You know, I don't want it to stick. But if it's not sticking, why do I go? See, you know, you have to. Now, once again, if you took some graft from, I get you kind of moving around because you're going to lubricate it, da da da. But if you just move it, it should.
You'd think.
Yeah, you would think.
Interesting. Okay. So what did you think of the advice about the stairs?
Once again, what's the hardest position to get up from? It's a hard position to work from.
Going down.
Going up or down. Why? Because let's look at how these legs function. Let's look at how the legs function. If you're sitting this way, the leverage is not on your favor to pull yourself up onto this leg. The leverage doesn't work out in your favor.
Okay.
So you have to get to a point where it works out into your favor. So,
okay.
So what's happening with the non-surgical leg? What can I do? I can push up on the non-surgical leg.
Okay.
That works out in my favor versus my weight being behind it. Okay, so let's go this way here. Remember the chimpanzees we saw?
Yes.
So how about we walk like they walk while we're trying to do these stair things?
That would be.
we have. I mean, think about it. They don't try to do this.
Right.
They waddle. So I think, you know, I won't have to say, hey, let's try and get you to waddle up the stairs.
Oh, interesting. That's an interesting thought.
This is always the hardest position to get up from, no matter what we're doing. We're just not built. The leverage is not on your side. Like even get them from a chair. I'm gonna push up on my arms first and get moving, then I'm gonna stand up. Because at that point, because this is what we talked about earlier, the knee joint is weird because we call it a knee joint. But what goes to the knee? I mean, think about what goes to the knee. The gastroc goes to the knee.
Right.
What else from the lower leg goes to the knee?
That's it, right?
That's it.
Yeah.
That's it. Everybody else is on the tibia.
The upper. Yeah, exactly.
So okay. So now, what goes from the upper leg to the lower leg?
You've got your long head of your biceps femoris. You've got sartorius. You've got rectus femoris. There's a gracilis, I think, crosses over there.
See the difference in flow?
Yeah.
You have a vastly different in flow from one side to the other. So that's what I'm saying. So think about all these muscles that are going downward,
right,
and attached to this lower part versus going upward and attached. So on one end, and think about this, on one end, I have, like I said, I got the gastric on one end of the femur. Who's on the other end of the femur? The quad.
Right.
So see what I'm saying? From a leverage perspective, getting up from this here is hard. Because what does the quad want to do? It wants to extend this, but it can't extend that. And there's too much weight on it to pop itself up this way.
Okay.
Whether you're going stairs or not, it's just you're not at a very advantageous position from a leverage perspective.
That makes sense.
So I see why that you would start the other leg, because it's in a better position to prop you up, prop you up, prop you up. Then you're in a better position to do what? Just extend the leg.
Got it.
Then you're to extend, you know, so yeah. I know people can't see what I just did, but okay.
They'll get the idea. All right, so the exercises that are, this is again, weeks 0 to 2. We've got ankle pumps, which is literally just pointing the foot
Yeah.
and flexing the foot. Calf raises, quad sets, which is your leg is straight out. You tighten your quadricep, you lift the leg a little bit. Straight leg raise, hip abduction, and isometrics.
Yeah. And so let's go through hip abduction. What they got to do with the knee again?
And it's usually, this is taught as a clamshell type situation.
Right. So what they got to do with your knee?
It doesn't.
So, and then let's go through ISO.
Right.
You got to do with your knee.
Right. It's all hip related.
You know, yeah, it's all hip related stuff. So you go through that, you know, let's go through the extension. Okay. Got that one. And what's the other one they had? What's the calf raises?
Calf raises.
What they got to do once again, to do a calf raise is not a calf raise because,
Right.
okay, think about this from a calf raise perspective. Calf can't pull that heel up.
Right.
So when you're doing a calf raise, it doesn't even affect the knee. It's not trying to do anything at the knee level.
Yeah.
So all these exercises are designed to do what again? I mean, so far we got what? We got an extension exercise.
Yeah.
Okay. And we got what other one that really affects the knee?
We got quad sets.
That's it though, right?
Yeah.
The rest of them don't affect the knee.
They don't. Now, it could be argued that maybe the goal of this first phase of rehab is just to get people comfortable with that leg again. So maybe that's why they choose these exercises.
You see, look, people can't see it in my face, but okay.
I just gotta look.
But where did this come from? Like,
Right.
I mean, because you look at these exercises, you go, but this has nothing to do with a knee. This has nothing to do with getting blood flow to the knee, which is gonna help it out a whole lot, you know. And then think about this here too. What do we know about inflammation? Inflammation is a good thing.
Yes.
Because that means things are being healed up. And what do
Right.
people want to do? If you do anything that creates inflammation, they tell you to stop it.
Yep.
Why? Isn't that healing?
Right. Which brings us to phase 2. Oh, and there's stretches too. I forgot to tell you about all the stretches. Because stretching is important. They're stretching, you're doing heel slides with a towel. You're doing a seated assisted knee flexion extension. You're doing extension stretches. You're doing a standing gastroc stretch because that seems like a great idea. You're doing a soleus stretch and you're doing a supine active hamstring stretch.
For my knee.
For your knee post.
I mean, if they come with a guideline, say, hey, we can give everybody the same thing to do. Just so, yeah.
So again, we've got, you know, a defensive linebacker doing this. We've got our soccer attacker doing this.
Right.
We've got our basketball player doing this.
Different sizes, different, and everybody's doing this to try and put it, but my knees under different demands than all these other ones.
Right. All right. So then phase 2, we're 3 to 5 weeks after surgery. The goals are knee extension range of motion, 0 degrees.
Okay.
That the quadricep can contract and that the patella can glide. So at this stage,
if patella don't glide, you can't move your knee. See, that's what's just cracking me up. Like if the patella, like, and we talked about that earlier. I don't want my patella to be stuck. We said that already. I don't want it to be stuck. If it's stuck, I can't move my knee.
This is true. This is true.
I hope it's been gliding. And why wouldn't it glide? Like what would be? I gotta rub my head now.
So we have exercises. We can start riding the stationary bicycle. We can start doing some gentle stretching for leg muscles, in addition to what was being done earlier.
What was the other stretching we did?
I'm not sure. This came straight from, again, Massachusetts General. I copied this down. Phase 1, phase 2. All right. So the exercises, we're doing some standing hamstring curls. We're doing some step ups. We're doing some step ups with marching. We're doing a partial squat exercise. We're doing some ball squats and a mini squat from 0 to 60 degrees. So we're starting to work through that, 60 degrees of flexion. We're doing some bridging. We're doing some more clamshells. And we're doing some stability ball bridging. All of the variations of the stability ball bridge, all of them.
Wow.
Can you identify any issues so far?
Well, yeah, I mean, once again, you know, we haven't got to the function of what the knees do as we walk and run.
Right.
You know, I mean, we haven't gotten anywhere close to what we're doing as walking and running or jumping, anything like that. You know, what this knee actually does in these situations.
Yeah.
And that's probably still, you know, that's still the base level of, if you ask somebody, what does the knee do? What does the knee actually do? And I think that's where the problem writes up at, where they, you know, because they were stuck with, you know, some people say it rotates. Well, okay, whatever. If you want to say it rotates, it rotates. You know, if it flexes, you know, okay, yeah. But what does it actually do while we move? What does it do?
Right.
I mean, why?
The common belief is that it extends the knee. Like that's what, you know, and flex, you know, extends the lower leg and flexes the lower leg.
Yeah, but what's doing that? Not the knee.
Not the knee.
You know, I mean, if you look at it, it's a muscle that's doing that, not the knee. And so, you know, even from this, if you look at it from this viewpoint of, you know, like I said, what is my knee doing? My knee isn't doing anything.
Right.
It doesn't do anything.
Yeah.
What is my femur doing? What is my tibia doing? I think that's how they need to look at it. What is my femur doing? What is my tibia doing?
This makes sense.
You know, and I have these connection points to, like I said, like anything else, there's a connection point, you know, from one to the other, you know, so that you can have, I mean, because if you don't have this thing and you have this muscle, then this thing is not steady. So you have this steady stabilizing thing called these ligaments in there.
Right.
So these other guys in alignment stuff and all that kind of stuff. But once again, what does the knee joint do?
Yeah.
Nothing. What does the tibia do? What does the femur do? Different story.
Right.
So I think that's where we have to just start looking at these things kind of differently, and look at this way here, you know. And this is why I keep saying this too. What was going at the knee when you were crawling?
Well, it's it's a pressure point of contact.
Pressure point.
Yeah.
So have they put somebody on the knee, see if they can take pressure again? So
far, no. This is not part of the protocol.
I think that would do more for the patella than anything else, than this other stuff they're doing. You're talking about gliding. You would have to glide at that point in time, you know, and we'll find out that we don't want to move around as I'm trying to crawl, you know, some other things. But yeah, how they looked into that there, like what happened to the knee as you were crawling?
That's a good point. And I don't know if like 3 to 5 weeks after surgery is too soon from the incision point of view to put someone on their knees.
Why not?
Well, I don't know. I mean, because you need the sutures the skin to heal.
Yeah, I mean, I get that, but it should be close. I mean, you've been moving.
That's true.
You know, so but what I'm saying is this here. What about just kneeling and getting up?
Right.
You know, what about walking? What about walking on your knees? What about crawling on your knees? I think those are better ways to see if this thing's holding up than clamshells.
Clamshells. Oh, wait until you hear phase 3 when we're 6 to 8 weeks after surgery. You're going to love this. Okay. So we're 6 to 8 weeks after surgery, which, you know, in surgery world, this is when you can start doing stuff. Like this is when, like, you know, tissues are kind of healing a little bit better. And
this is where it gets fun. This is where it gets funnier. But go ahead. I've been waiting on this part.
Okay. And we're stopping after phase 3. So if you guys want to hear the rest of it, you have to go to observing movement and check out the rest of it. So phase 3, 6 to 8 weeks after surgery, we have leg press machine, hamstring machine, hip abductor and adductor machine, hip extensions, the Roman chair, seated calf raise, and we have squat to a chair, Romanian deadlift, because as you have taught me, that's such a leg exercise, single leg progressions, lots of step up variations, lots of lateral step up variations, partial weight bearing on the single leg press, slide board lunges. Then they introduced balance and proprioception using single leg balance. And again, your favorite word, they introduced perturbation training. That's phase 3.
People, yeah. And think about this. Let's look at what happens when we walk. What the knee does when we walk versus knee run versus knee, you know. And if you look at like from a weightlifting situation, say I'm doing Olympic lifts. I got this small range, you know, and which way am I going to go? I'm going to swing over this way. You know, if you look at riding a bike, if you look at running, which way does it's going to swing? You know, I need this thing to swing freely again. You know, and where the exercise teach me how to, like I said, where the exercise teach me just how this thing can swing again. But like I said today, I think the biggest thing, what I figured out today was just that same thing. Can I relax to let this thing float?
Which I don't know if you've ever worked with someone post ACL repair. I have, and there tends to be a lot of tension in the leg.
Yeah, I imagine that that's part of it, you know. So if there's tension in the leg in the system, then all of a sudden the plyometric effect doesn't work. The fascial system doesn't. A lot of things don't work because that's part of that. You know, I need that compression. If I can't get to the extension, I can't get to the compression.
Right.
And like we saw earlier today, you know, where you see this total relaxed limb.
Yeah.
And then all of a sudden it's the ground. And then we see this rapid stretching, rapid shortening in a sequential way and stuff like that. So if you never practice that again, I mean, just something as simple as practicing letting the leg just drop, letting the leg just swing freely, you know?
Right. And when I say I've worked with people post ACL repair, I mean, I've worked with people like a year or 2 years post ACL repair, and you still see this tension that, at least in the people I've worked with, that's still there. Which it negates the ability, and it negates the ability to control the collision because they're stiff when they land.
Already, yeah. And you don't let it. So you're missing compression at you know, and so we're missing these things as we go up the chain. But the biggest thing is, you know, to feel what's happening.
Right.
You know, if I can't feel what's happening, how do I learn this movement again?
Well, and it seems like a lot of these exercises, I mean, yes, step up variations are closed chain, but how close, I mean, it depends on how they're teaching them. If you're actually loading the leg in a way that would be similar to sport participation, because a lot of stuff's taught really upright, right?
Yeah, yeah. But even in sports participation, just walk your way through it. If say, just walk your way through sports, just give us a sport.
Let's go basketball.
Okay, squat it, and what's going to happen? I'm going to roll for it into a crawl pattern. I'm going to come out of a crawl pattern, basically. You know, another sport.
Let's go basketball, or sorry, not basketball, soccer.
Soccer, squat it, crawl position.
Okay, football.
Squat it, crawl position.
And the squatted crawl position is happening even when they're cutting. I mean, because that's the big thing, right? The ability to cut and pivot is one of the issues with return to play with ACL repair.
Yeah, but a lot of times too, you know, when they cut and pivot, the leg, it's how they load, unload.
Right.
Like one of the things I've realized in watching some of these things is this here. And this is what we talk about. The really elite athletes, they move both feet at the same time.
Mm-hmm.
So do they even teach them how to do that? Because now you have this leg that's not communicating properly.
Right.
So, and like I said, I posted something yesterday where the soccer guy's coming in. And he made his cut while he was in the air. So both feet in the air, one foot goes left, the other foot goes right. And when the foot goes right, the defender jumps to the right. Mm-hmm. Well, guess what? When he landed, he was on the left. Mm. This is all while he's in the air.
Right.
So it wasn't no serious stress on the leg because everything he did while in the air.
Yeah.
So, and I think that's even like with basketball, they reposition their feet in the air. There's really not one foot on, at the elite level. They're moving. So when they move they're in the air because it's easy to do what? Move.
Right.
But they don't have one foot on the ground trying to move the other foot. That's not really how they do that.
Interesting. So there's room for improvement with this.
Oh, big time. But you have to go back and look at the actual movement. I mean, you got to go back and look at the movement, what's going on, versus, you know, strength. Because those are all, and those are even strength exercises. Those are just with the hip, my hip wasn't a problem,
Right.
you know. But how freely can my legs swing now? Which is what I'm going to need to reposition it.
Right.
You know, how steady is my knee that my femur can rotate over the top, which is what I'm going to need to run.
Right.
You know, so I think that becomes just a lot of like, what does the actual, so if we don't really understand what the actual sport movement requires, how can we really do this protocol?
Which is what you will all learn in part 2, if you choose to go to observing movement and check out the rest of this. So thank you so much for your time, Adarian.
Thank you.
Yeah, and we'll see you all next time.